Anthony here from Physical Therapy and Balance in Physical Hazleton, here to talk to you guys about squatting. In this edition of Physical's exercise series, I'm going to talk to you about squatting, the history, what it's good for, and how it's done. So let's discuss the history of the squat. So squat is one of the most primitive movements that we have. We could do it as a baby, and we could do it throughout our whole life during all activities, and it's needed for all activities. But the first recorded history of the squat as an exercise was in 1919 between two German weightlifters. In 1921, a German by the name of Henry Steinborn brought the lift to America and started introducing it in lifting competitions. So let's talk about why we should do the squat and what it's for. So obviously the squat is a leg exercise that focuses on the quadriceps, the front of the thigh, the buttock, the glutes, the back, your erector spinae, which is the muscle in your lower back, and your abdominals. For those of you who are trying to get in shape and fit, this is going to help tone your legs and buttock. For your everyday person, it's going to help with your activities of daily living, being able to pick something up from the ground. And then if you're an athlete, it's going to help with strengthening and power for more explosive movements like a jump or sprint. They actually found that weakness in the glutes and lateral hip could actually lead to injury in the knees, ankles, and lower extremity. So squats can be very beneficial for any person of any age. So now you know what a squat is, let's learn how to do it properly. So let's break down the form of a squat. So when you squat, you want your feet to be about shoulder width, maybe a little bit greater than shoulder width apart, and slightly toed out. When you start to descend into the squat, you want to hinge at the hips, pushing them backwards, trying to place your weight through the middle of the foot, closer to the heels if you can, so you don't rise up on your toes. Once you get to the bottom of that squat, you may want to make sure your back is flat and straight. Weight is through the hips, and knees are not further displaced than your toes. As you're coming up, you want to push through your feet, pushing through the ground, extending at the knees and hips until fully upright. So common mistakes, mechanical problems that happen during a squat that could lead to injury that you want to really focus on as you're doing them is first what we call a valgus collapse at the knee, where that's when the knee caves inward. So you see this a lot, usually at the bottom of the squat when someone's trying to come back up, their knees will cave in, causing increased stress on the inside of the knee, pushing the kneecaps out. It can lead to a lot of different problems at the knee joint. Another thing you want to avoid is too much forward flexion of the body. If your back's not straight and in good posture and it's too far bent forward, you can lead a lot of stress to the lumbar region, causing some problems there. Also, you want to make sure your ankles are stable. You don't want to be bending too far in, while you're squatting. That also lead to those knees coming in, and it can also lead to some stress at the ankles as well. Now that we talked about form and some common issues that people have with the squat, next question would probably be, how many should I do? And that's a question we get a lot here, and there's no right answer for each person. So if you're over the age of 60, a good rule of thumb is to look at a 30-second sit-to-stand test. This test shows how many squats or sit-to-stands you could do within 30 seconds, and it correlates your risk of falls. If you are greater than a certain number, your fall risk is generally low. If you are below a certain number, according to the graph, your fall risk is higher. So if you're in that high fall risk area, you want to really work on these squats and these sit-to-stands in order to decrease your chance of falls and increase your overall athletic performance, overall function. Now, if you are someone who's getting into weightlifting, there's actually a chart out there that's been studied that shows body weight in correlation to what your numbers should be. And it shows what you would be if you were a novice, a beginner, intermediate, advanced, or an expert elite lifter. So if you want to compare yourself to that, it's a great tool to use to see where you're at in that. My rule of thumb is if you could do 3 sets of 10 to start, just body weight, and you have good form, good mechanics, and it doesn't hurt at all, start adding a little bit of resistance. If you do those 3 sets of 10 and you feel real sore, fatigued, and you feel like your form was breaking down, then you want to drop off a little bit, either in sets or reps, and then kind of take it from there. So if you feel like you're not ready to do a full bodyweight squat just yet and you want some variations of it, I have a few for you. So the first one I'm going to show you guys is a wall squat. So that's with using the wall as a support system for your back. So your back will be against the wall, your feet will be out in front, and you're going to slowly descend using the wall as a kind of like a support system to help glide you down and then pushing back up. It'll allow your legs to work without having to worry about the stability of your upper body since it's going to be against the wall. Another variation would be a upper body assisted squat. So this would be using something like a TRX or a bar or banister, chair, table, whatever it is. By using your arms to hold on, again, you're taking out the component of balance in it, and you're just able to focus on the mechanics of the hips, knees, and ankles. A third variation would be something like a box squat or a chair squat. So this is using a target to kind of assist you with your cueing. So as you're going down, you're trying to aim for the box or the chair or object that you place down. This could be at any height depending on where you feel comfortable and where your strength levels are. And this will give you, like I said, that cue to know how far you're going and where you're going to. For those of you who find squatting with body weight to be easy at this point, there's a lot of ways we can make it harder. So the easiest way would be to add some weight. This could be with anything like a dumbbell, barbell, it could be a backpack filled with books, it could be water jugs, it could be anything to add a little bit of resistance, add a little weight to the squat. Another variation could be a single leg squat. So now we're adding in both balance, coordination, along with strength of one limb at a time. All right, guys, so now you know the history of the squat, how it's done and why it's done, and some variations on how to do it. So make sure you get to squatting, practice it, use it. It's a very valuable exercise that could help you in your everyday activities all the way to athletic abilities, whatever it is that you're trying to get better at or move more pain-free. So if you have any questions and you feel like you might not be doing it right or something feels wrong, please feel free to give us a call or talk to your local physical therapist. We'd be glad to help you out. So remember, let's get physical and let's get squatting.
Hi everyone, this is Ting here, physical therapist at Physical Therapy Balance Centers, and today I'd like to share with you a couple of things that you can do to help with neck pain, and especially if you can't turn your head to one side or the other, which unfortunately happened to me this morning when I woke up. So just a couple of quick little tips you can do at home to help with the problem. So number one, what typically does happen to cause that is either a muscle gets tight, the fascia gets tight, or the joint gets tight. So I'll show you two interesting little techniques you may not know about. So first of all, the muscle that is usually involved when you can't turn your neck is usually the upper trapezius muscle right here, and also the paraspinal muscles that come through this area. So a great way to work on them when you're really tight is to grab yourself something like a Theracane that I have here, or if you don't have one of these, grab a tennis ball or a cane or something that you have at home as well. What you want to do with it is find the area that's really tender, typically it's right in the middle, put the knob right there and then push down on it fairly firmly so that it's fairly painful. And you want it to get painful initially, but as you hold on to it, typically around about a minute or so, the pain should start to settle or release is what we say in the physical therapy world. And to make it a little bit more effective sometimes as well, what you can do is as you have that pressure on there, you want to stretch your neck a little bit to the left. And what that does is it allows that muscle to stretch out while it has some pressure on it, which can be very effective at loosening up trigger points and tightnesses. The other key area is also in your neck and the paraspinals. So your neck basically goes from your skull all the way down to where that point was. So anywhere along that line, if you just feel with your fingers and find an area that's really tender, and mine is right here, what you want to do is you want to put that knob right on that spot and then pull it across about 45 degrees this way so that you can get some pressure on that point. Similar thing happens with that other trigger point. As you hit it first, it may be pretty intense in terms of pain, but as you hold onto it after about 30 seconds to a minute, that pain should subside. If it doesn't subside, get off it because you're probably not on the right spot, or it's probably not a trigger point. So at that point, once you get that pressure there after about 30 seconds, similar type thing, you can turn your neck a few times, or you can just tilt to the side, making sure you use the cane to follow you around. So that's one little thing you can do with the TheraCane. And if you find that not very effective, a way to do it is to do it laying down, because that way your neck muscles are relaxed, which can sometimes make it a little bit more effective. Technique number 2 works on the fascia and the joint. So what you want to do again is find that area that's a little tender, which for me is right here. And I'm having troubles turning my head to the right today. Right about here, I'm getting a little stiff when I go that way. It's a little sore, but it's not too bad. So what I want to do is I want to find that point. I'm going to use my right hand, and I'm going to push that up towards my eyes in that direction right here. So my hand pressure is going to go in and up. So right on that point, I'm going to push in and up towards your eyeballs. And at that point, I'm going to start turning my head to the left, and I'm going to follow it with my fingers. So I'm just going to basically turn to the left as far as I can, and then come on back again. I'm going to do that about 5 to 10 times, and just trying to get as far as you can. And what it should feel like is it should be less painful than if you didn't have your finger there. So I think that's 3, 4, and 5. And with my finger there, with fairly firm pressure, I don't feel too much pain there. So once you've gone to the opposite side of where the pain is, you want to use your other hand, put it in the same spot, similar type thing. You can use 3 fingers, put it in spot, put some pressure in there, and push up towards your eyeballs at about a 40 to 60 degree angle. And at that point, we're going to turn towards the pain now. So I'm going to turn as far as I can to the right. Same thing. I'm going to do about 5 times. 2. And it should be less painful than if you didn't have your finger on there. If it's more painful, move your hand around to another spot. Move it up or down until you find the point that makes it feel more comfortable. So I lost count there, so I'll do a couple more. 4, 5, and right now I'm a lot less painful than I was. So once I get everything and done with that, I can just check my motion again. To the left, it's relatively pain-free. To the right, I think I made a few degrees there, and it's not as painful as it was. So if you're having neck pain at home, especially if you can't turn your neck to one side, give those couple of techniques a try. That might just help with your pain. Thanks for having us. Joining us today, we have Megan Baran, physical therapist extraordinaire, and Anthony Damiano, physical therapist extraordinaire number 2. Thanks for joining us. And so what we hope to do with this forum is just hopefully answer your questions about certain conditions that you may have. So what we did today was we scoured the internet, had a look at Google searches, and found out what the top searches that were out there for people for knee pain. So we're going to discuss some of the top searches out there. Obviously, one of the biggest questions that gets asked is what causes knee pain, right? So there's a lot of different causes for knee pain, and the main questions are what causes knee pain? Is it mostly arthritis? And what causes knee pain in the front and the back of the knee, which I guess a lot of people out there get pain in the back of the knee.
Mm-hmm.
So first of all, who'd like to answer the question about what actually causes knee pain?
Oh, that's a loaded question.
Yeah, I was just going to say it's a low question.
Yes.
So that's what our job is to figure out. Obviously we want to look at the whole person. We don't want to just look right at the knee joint. We have to go up and below the joint as well to figure out, why there might be some increased stress at the knee. It can actually be related to weakness in your hip. So, there's a lot of different muscle imbalances that can contribute to that.
So of the people that we see in the clinic with knee pain, what would you say were probably like the top 3 causes that we see in the clinic?
Well, number one off the bat would definitely be arthritis.
Right.
Probably the most
Definitely.
commonly complained of problem that we have, especially in any patients over 55, 60 years of age.
Mm-hmm.
And then from there it gets kind of close. I would say patellofemoral pain syndrome would be kind of a number 2, which is basically just an abnormality or mechanical problem happening at the kneecap. And then 3, I would probably go with a meniscus damage of some sort,
Right.
whether it be medial or lateral meniscus damage, whether it be anterior, posterior, front or back of the knee. That's probably number 3.
Right. So why don't you, for the people out there that may not know, just describe a little bit about patellofemoral pain that you were describing.
Okay. So when you look at the knee, there's 3 main bones. You have your femur, your tibia below it, and then your patella, which sits, right in the middle. And that's a small bone that has no exact joint congruency. Congruency. I can't talk.
That's a big word there, Doctor.
Yeah, I know. I'm trying to stretch my limits. Anyway, it's not a true joint, so it's kind of floating there. Is what I should have went with.
Right.
And if it's not controlled properly with either muscle activation and strength or with mechanics of the knee or hip or ankle, as Megan discussed, it could track poorly. It's supposed to stay inside a groove. If it does not stay inside that groove, it'll track, certain directions, most likely to the outside.
Right.
When you get that lateral tracking, you get some inflammation and rubbing underneath that kneecap. That happens too many times. You can cause damage to the cartilage under that kneecap, and people will complain of pain, mainly when they are bending, going downstairs, squatting, any of those motions.
Right.
Will cause that pain.
Yeah. So from my experience in seeing our clients as well, I would say even if you have arthritis and other pains like from meniscal tears or tendonitis of any sort, they do eventually manifest into patellofemoral pain, because what happens is when you have these other injuries, your kneecap doesn't track properly because you get weaknesses and tightnesses, and if it doesn't track properly, then that kneecap problem develops, which on top of the other problems can make things more severe. Would you say that would be fairly accurate?
Definitely.
Yeah.
You saw the domino effect with
Right,
other
it's the
things,
domino
yeah.
effect. So, and again, in my kind of experience, I would say that probably about 70% of the people that we see in the clinic would feel better with some sort of treatment to help with the patellofemoral tracking. Even though it may not fix the underlying problems such as arthritis or meniscal tears, it might help reduce the pain. And if we can help reduce the pain, it might make those other problems more manageable. So good job there,
Yeah.
Dr. Diana.
I was just gonna say, going off of that too, if we can reduce the pain, you're as the patient is going to be more likely able to maybe do some of the exercises that we would want them to do that are going to help that underlying problem.
Okay.
more likely able to maybe do some of the exercises that we would want them to do that are going to help that underlying problem.
So let's talk a little bit about meniscal tears then. So tell us about meniscal tears.
So your meniscus is a soft tissue structure that sits in your knee joint. It provides shock absorption, helps give the joint some cushion there. So sometimes, it's something that just breaks down over time with aging, like everything else in our body, wear and tear. Sometimes, though, it can be related to a specific moment of injury. So, if you're an athlete or somebody that does a lot of sports that involve rotational kind of twisting stresses on that structure, that can break that down as well.
Right.
So when you don't have that cushion in the joint, there's going to be more rubbing. It's not going to be tracking like it should in the joint, which is going to cause pain.
Yeah, I mean, the only thing I would add, and we said it before, Megan said it a couple times, the greatest misconception we can have is that the area of pain is the source of the pain.
Right.
We have to look at the body as a whole entity, and kind of really assess what's going on. And I think that's what we're here for. That's why we're in this profession. That's why we went to school for so long and studied so hard.
7 years, huh?
Yeah, use the expertise. Yeah.
A long time. All right, so thanks guys for joining us. Hopefully we answered your questions today.